Pita sarga pita dharma pita hi paramang tapa. Pitori prima pante piyante sarvati hola. We say if you worship your father, that is enough. So everything is there. So you sarga matra suppose. So easily do not neglect your father wherever you may be. So do not send them to old age home. Yes. Now today we are going to talk about the ankle joint. Ankle joint is said to be one of the most stable joints. Stable in the sense that you have these bony configurations and ligamentous structures are such that it is one of the stable. That is why osteoarthritis is a bit less in ankle joint comparing to knee joint. Though both of them are weight bearing joint. Both of them are weight bearing joint, it is said the per square area is bearing more weight, particularly talus. Even then, the degenerative process is a bit less comparing to. But ankle mortis to you have to know what are the components. Sir, what is tibial plafon? Plafon means what? Roof. Is formed by what? Formed by the distal articular surface of the tibia. What is the shape of this? Shape is, it is said anterior-posterior it is concave and side to side it is concave. 1 point. Number 2 is medial malleolus plafon. Then what is this? And this is your lateral malleolus. And the articulating with talus. What is the shape of the talus? Trapezoid for what? Because anterior-posterior diameter, transverse diameter in the anterior part is more than the posterior. How much? Almost say 2.5 millimeters. So it is said while you are doing lock, dorsiflex, it is lock sorrow, because the lateral diameter is being engaged here. This is one of the reasons behind they are saying that we will talk about this. Now while passing this screw for syndesmotic screw, you said that you are supposed to do dorsiflexion because it will prevent compression. That is why you locked it in the maximum distance the diameter, so that this compression screw which you are applying from here will not do unnecessary compression, and that will constrict and prevent the playing of this ankle joint. That is one of the reasons behind. Regarding talus, it is one of the bone where you do not get the attachment of the muscle or ligaments. Ligaments are there, but as such no tendinous attachment. So the blood supply, this part is very much precarious, and is coming from the inferior part, sustaniculi part. That is why it is one of the bone which goes for your avian and other problems like your flexor and femur. You get so many problems because of the precarious blood supply. Two reasons. One is most of the part of the talus is articular, so almost 70%. So this is neck, this is head. This is also articulating with what? Clavicular. And this part is the superior part, medial part, lateral part, all are articular surface. Again, inferiorly you have the subtalar joint, which is also articular. Subtalar joint. So that is why talus is a bone which is having precarious blood supply, and non-urinary and other problems are more so in talus, like flexor and femur. That is important because most of them. But characteristically also important, then it is one of the bone which is bearing maximum weight in the per square area. So compared to that, it is getting less blood supply. Right. Now in the ankle joint, what are the movement you get? How much? Almost 20-30. And it is 45 ligament. How much you need to walk for walking purpose? What is the range of movement?
10 degrees.
Almost 10 degrees and 20 degrees. This is enough. So this part is, so that is important that you do. Even if you arthrosis, you fix it. Even if patient does not have much of a difficulty, particularly in ankle arthrosis, the functional deficiencies are quite less. Now let us talk about the certain ligaments here. What are the important ligaments that holds it? Medially you do have
deltoid ligament,
what are the parts of deltoid ligament? There are two. One is superficial, one is deep. You are supposed to understand. What is the role of the superficial part? What are the parts? So you have one is coming up to the
tibionavicular,
one is coming up to the
tibiocalcaneal,
and see, superficial part is holding the wider part, but deeper part is mostly holding what? Talus. So this is important. This is one of the most important stabilizers in the medial side. One is extending up to the navicular, that is calcaneum superficially, and deeper part is mostly articulating with the talus to get the most stabilizer part. In the lateral side, what are the ligaments here? This is coming posteriorly.
tibiocalcaneal, posterior tibiocalcaneal.
Calcaneum. Another is going to talus. Clear, sir? These are the lateral stabilizers. Now, what are the ligaments holding this syndesmos?
Anterior, inferior,
This is one of the very important structures. Anterior,
posterior,
and what about the medial? What is the continuation? It is the interosseous ligament. So the interosseous ligament continuation is here. So this is a holding structure. Out of this, which is more strong? It is posterior. It is said that the posterior part invariably does not go rupture, but it causes avulsion of the flexure. The posterior medially to form. Most of the time it is because of the strong posterior part, it instead of going rupture, it avulses. It takes a boom. And it is said that if you do the reduction of the lateral malleolus, automatically that fragment, because it is so much attached to it, this fragment in particular. So this is very important structure. That is why it is invariably, instead of getting rupture, causes avulsion in itself. You do get a very classical fracture in case of children here. What is the fracture?
Talus,
Fracture. What is attachment here? What is this tubercle known as?
AITFL,
And there is the attachment? Separate. Correct. He is right. It's tubercle. One tubercle is here, another tubercle is there. Both are very important. And this is classically you will see in case of your children, you see as a yellow fracture because of this avulsion of this. So these ligaments are important for stabilization. So anytime any sort of injury, so it is a ligamento-osseous stress. What is the meaning? Ultimately, suppose, okay, we will talk about the various mechanisms of injury. Wherever it may be, whether it is going for varus or valgus, whatever it might be, ultimately what happens? There is a stress. Stress to what? For ligamento-osseous complex. Now, which is going to fail? So it depends upon which is strong. So that is why sometimes you do not, injury is more, but X-ray is silent. Why?
ligament
Ligament is gone, but the bone is still intact. That is important. That is why this, depending upon the age group, the picture is different. So that is why do not only rely on the X-ray. So you may need to go further investigation to know exact pathology injury. Ultimately, thing is that I am having this your varus. So there will be stress to the lateral column, and there is a compression in the middle side. So what is stress? It is stress in the ligamento-osseous complex. Here I got same thing. So who is going to fail? The weaker one is going to fail. Which is weak in what age group? Bone is yes, that is right. That is very important thing. What is going to fail? It depends entirely what is going to start, because all body structures are under stress. Is going to fail which is weaker. Weaker depends upon the age also. That is why. So do not only rely on the X-rays. Do not rely on the X-ray. So you need to do further investigation. Anyway, now what are the common injuries you encounter? What are the classification? There are many. Post is a person who described this fracture in 1756, but before invention with X-ray. That is why Post name is still coming out. Though it is nowadays based on the CT scan or X-ray, but he has described all these fractures long back in 1756, before invention the X-ray. Before X-ray. That is why Post's name is still coming for this fracture. Nowadays we do not talk about Post. We talk about the what classification?
Log Hansen.
So this depends upon what? Mechanical injury. So what is mechanical injury now? Commonly?
Supination and
So
pronation.
there are three things. One, sometimes this. What is this?
Supination.
Nowadays, the supination, they are saying it is a varus. Is it valgus?
Yes, sir.
ठीक है sir? No. They are saying it is inversion. Nowadays, more better terminology they are saying this go to the valgus, varus. No. Inversion. Now, before ankle joint, we know the movement. What about the subtalar joint?
So inversion.
What are the parts? There are two parts. The successively is there, the posterior part and the anterior part. What is the function of subtalar joint? How much you get inversion? And what is the range of inversion? Cohiba. Not much. 10, 15 degree or 20 degree like that. What is the importance of this function? When a person is falling, supposing he is on an uneven surface. So if something is hitting here, the limb will go like this. Yes? If it is something falling on there, it will like this. So where it is going to accommodate? It is subtalar joint. So in a case where subtalar joint is in pathology, probably this will go more easy. Are you getting my point? So the subtalar joint is very important in TPT because particularly when you are uneven surface, patient is having this, that will be accommodated in the subtalar joint. So talking about the mechanism of injury, let us think very simple. There will be combination of or pure. What is combination? What is pure? Pure is a patient is having like this. I am having injury like this. What is this?
Supination reduction.
Inversion. That's it. Now we will talk about the combination means in inversion there is also rotation factor. Again in the inversion pure or it will be accommodated with rotation. So that is it. Let us simply understood that these are the two mechanisms. One is pure, another is combination. So combination is mostly associated with rotation. Yes or no? Purely if you are explaining this now, what will happen if there is a pure injury like this? What will happen? Simple thing, this side will be pull, this will be push. Yes? This will be pull, this will push. So push and pull, these are the two factors working. Now as I said already, which is going to fail? It is either the bone or the ligaments. Yes, depends upon the strength which is going to hold what. So from the characteristic point of view, if there is a pull, what is the picture of the flexor?
Avulsion.
That is from the X-ray one can explain from later on that from the flexor configuration one can also explain the mechanism. Though this classification is actually they have studied in cadaver. This is cadaveric study. So this cadaveric study was done and this classification is based on this. But as such from the X-ray one can make out from the flexor configuration that if there is a transverse flexor means what? Avulsion. Avulsion, why there is a avulsion factors? In between transverse. So if there is a pushing, so it will be almost towards the vertical line. Yes? Remember that picture. So if a person is coming to us with an X-ray where there is a transverse flexor here and where there is a vertical sort of flexor is going in this line, what should be the mechanism of injury? Simple thing. So if you adhere to the basic principle, you will find this is also the varus. So this patient must be having like this. That is why this flexor is being pulled and that is causing the flexor avulsion. It's transverse flexor. So if it is pushed, the axis will be almost towards the vertical line, so flexor line will be like this. Just reverse thing may also happen. And in the reverse thing, what is happening? There is a pull. So if there is a pull, what should be flexor configuration? Transverse. Transverse is long axis. Okay? Now as I said, if it is pushed, then what will be happening?
Vertical.
Here?
Oblique
Combinations. Most of the time you will get what sort of flexor here? Combination. Because crush. Now who is going to fail?
Bone.
Either here, either here. Sometimes there is involuntary also the syndesmos. Or if the fracture is happening here, most of the time what type of fracture you will get? It is crust. This is crust, it is what? Comminution. Because it is crowded. So that is why you will get this sort of fracture here. Instead of, because the holding power is there, that is why it may dissociate. It may dissociate. It may go a bit high also. But most of the time classical fracture is there, it is a tendon fracture here, and it is a crowded fracture, crowded leads to comminution fracture. X-ray? Yes sir? So you know. So why is it going to fail? This is a transverse fracture. Now, you may not get this sort of fracture here. Instead, you will get a big swelling in the examination. There is a chymosis in the middle side, but there is a comminution fracture here. What is the meaning? Meaning probably there is a rupture of the delta ligament and there is a comminution of the fractures here. Is comminuted fractures in the delta ligament. So that indicates it was like this. And like this is a grounded, that is why it becomes a fracture. But here it may be silent one something. So that is why sometimes we do not find in the X-ray, but there is a fracture. So that indicates that there is sort of muscle comminution. That indicates that there is injury to the ligamental complex instead of fracture. So now what is the combination of injury? Now these are a pure injury. Pure. Now in the pure you have this combination. This rotational factor is there. Now if the rotational factor is there, which combination is more common?
Supination.
Acceleration. So if the supination acceleration, what is the mechanism? Like this, and there is a rotation. There is rotation. So talus is rotating. So if the talus is rotating, who is going to be hit first?
AITF.
This ligament. Anterior inferior talus. So there will be dissociation here. Now the force may limit there. So patient may not have anything, but there will be tenderness there. Stage 1. If it is more, then going to hit what? Lateral malleus. If it is hit rotated like this, that's it. In the fibula you have three types of one is sometimes we say there is a combination of comminuted fracture. It is because of crushing. But if the fracture is an oblique type of fracture, which is going like this,
And to inferior to posterior superior.
going like this, most of the time you will find this is a oblique type of fracture. This is what?
Rotation.
Rotation fracture. So it will be rotating like this. So there is a mirrors and there is equally there is rotation. Particularly football player, they are hitting this, then their body is rotating. So this part is fixed and he is rotating. So that is why there will be rotation element. So in the rotation element, if the force is working like this, it will cause what? Oblique. So initially there will be dissociation here, then you go for fixation. Now if it is going further, this stage 2, stage 3,
So posterior malleus or posterior inferior.
and finally they favor
Medial malleus.
and see, is anything more than this? Sometimes
Deltoid.
dislocation. It may go for dislocation. Some you will find the talus is coming out. It happens. So as such, this is the sequence of the injury. So anytime he may be stopped. He may be heavy stage 1, nothing much. He may be stage 2, which can be treated by continuity. Further it is going, then it may go for more operative treatment. So initial stage, most of the time, this stage can be managed by conjunctive. But if he going further, means he is going towards the operative. Principle is same. Okay, our sequence of event is same. Now reversing may also happen. And what will happen? Condition and resuscitation. Sequence of events are reversed. Reverse, something can happen. Yes, sir. So again, it may be stopped in the between, or it may happen. It may go up to the dislocation. Ekdom extreme point of view, why that dislocation? Because if we trimedullary fracture with the dislocation, it may come in extreme. So there is a dislocation with ankle also. Now, it is so how do you do radiologically evaluate this X-ray? How do you do for a diagnosis? Clinical examination is important. Many times there may be associated dislocation. There you have to work very quickly and swiftly because why? Because all these tissues are ligamented and all strong structures are there. So if it is dislocated, it invariably causes vascular injury or the nerve injury. So it is not very accommodative one. It is in case of your forearm serum dislocated, flexor displacement, that's not of natural mass. But here things are a bit different. The skin is not accommodative. Not accommodative. This part is more ligamentous and smooth type. So it cannot accommodate beyond a limit, the swelling or anything. So that is why it is clinical examination important. If the dislocation is there, probably it is said is better to do early and immediate reduction of the dislocation, keeping aside the other things. Because invariably it may cause damage to the neovascular system. Okay? And if you keep it like this, the skin is very much always taut. That may go for a sloughing if you keep it long. So here things are a bit urgent. So one should reduce this as early as possible. Particularly dislocation part, not talking about the other thing. 1 point. Now that is clinical examination importance. Neurovascular examination is also important. Other things also important. Now how do you evaluate this X-ray with the X-ray? What are the common X-ray you will suggest?
Epilateral mortise.
Epilateral and
Mortise view. What is the importance of the mortise view and what exactly do and why you have to do? See, there is a question, huh? Internal or external?
Internal.
Because why so? If you look at this here,
Talus.
lateral malleus and medial combination, you will find they are a bit posterior.
Yes.
And it is also longer. Yes? So it is a bit posterior. So that is why to know this space you have to do so that this things comes perpendicular to the beam. Perpendicular to the beam, that is where the limit. Now keeping the simple thing, AP and lateral view are not talking, but what about the mortise view and what is the significance? What is the normal gap? Normally gap 5 to 6 mm. If it is small, it indicates a radiological dissociation of the shape.
Yes.
One can do clinical examination also. What are the tests?
Stress.
So other tests are also there. Some in case of your
It's anterior, posterior.
important tests are there. Now look for the varus fungus test. There is Bayer's test also important. To look for the indicative, particularly there is no section. So to know the extensivity of the soft tissue, ligamentous structure, one can do Bayer test, varus fungus test. Even earlier days, examination of the patient under CM, X-ray, stress view. Stress view to know the integrity of the ligament. This is another X-ray. Okay? So stress views are important to know about the integrity of the ligament complex, how is it unstable. But as such for the X-ray, these are the X-ray you know, and the importance of this view, particularly during internal rotations and through the joint. Space should be 5 to 6 mm. Normally, it should be going beyond it, indicates the dissociation of the dissociation. As such, in the practice also squeezing tests are there, stress tests are there. So it is sometimes difficult to assess because of the fact that there is so many injuries around, no one cannot pinpoint it. Okay? Now, how will you manage this patient? Check.
Only ligament injury, then sir, conservative management.
As I said, it depends upon the degree of injury. Most of the time we go rotation. This injury is supination and acceleration is common. So this is most of the common injury. That is why, depending upon the extensivity, you will decide. So stage 1 and stage 2 one can do conservative. If further it is going to go for operative treatment. Now what is the operative treatment? How do you start?
Fixing the fibula and gaining the length.
Okay, upon fibula now that depends upon where you are going to put the incision.
It depends on the fracture.
Depends upon the what?
It depends on the fracture fragments.
Fracture fragment 1, number 2.
Sir,
Number 2.
So skin condition.
Posterior.
Posterior mille.
Posterior major, yes.
Posterior part means what?
Posterior mille fracture.
Posterior malleus. Posterior malleus again two parts.
Posterior lateral,
One is
posterior
medial,
medial.
one is lateral.
Yes, sir.
So that is why. So that is why if you that incision depends upon involvement of the trimeters, third method. So if it is heavy in there, one can go and address these two problems in a single incision. So they are approaches to be different. If it is pure. Now again there is lot of things that they are coming up that regarding trimedular flexion in the third method. So earlier this concept was there, if it is not involving much in the articular surface, better not to. Nowadays it is, since it is involving in the ligamental complex for better stability, one should go in. The concept is changing to go for more operative. You my point? So there is a concept. So recent concepts are coming up. Try to address this operatively to give a stability supporting. But earlier concept is when if it is like the corner process. If it is not involving much, you ignore it. Stage 1, stage 2, stage 3. If it is more, you have to go. So that is it. But nowadays it is approaching more toward the surgical address in the trimedular flexion. Even if it is fragment is small. So in this situation, the incision is a bit posterior. Now where you put the incision? In between lateral malleolus and the what? What? No. Tendacles, in between. So what is the more important structure coming up here?
FHL.
Swell, correct. Swell. This is very important thing. You have to be careful when you burn C-section and you have to take care of it now. Otherwise lateral incision is not that different. Where you want to go a lateral plating, plate fixation nowadays, your contour, pre-contour locking plates are coming up. That's a different thing. Earlier days 1/3 tubular plate can be also useful. Only question is that whether I am going to address this endoscopic screw or no. Only thing. So three things are there. In the lateral side, one. Am I going to address the posterior part? If so, I will put the incision like this. In between this and in between. Take care of this one now. So in this situation, this one can put the plate in posterior surface. This is what type of anti-glide plate. This can be addressed with the help of your buttress plate. So three-plate sort of thing. Nowadays pre-contour plates are coming up. That's a different thing. Otherwise it is a buttressing. The principle is buttress. Here principle is anti-glide. ठीक है sir? So fixation, incision. Depends upon involvement. I am putting here, putting here. ठीक है sir? Only question is that whether I am going to do something for it or not. That depends upon in the operation theatre also. One can pull and see what is instability and stability. Yes sir? Okay. So how to address this point?
So after fixing all the fractures, we should check for the integrity of the
okay.
synthesis.
If it is instability is there, then you are going to put a screw. Now what is the mechanism? How do you address it? Yes sir?
30 to 35 degree.
30 to 35 degree?
Posterior anterior.
Anterior?
And
Posterior medial to anterior.
Yes sir.
Posterior lateral to intermediate.
Join this AB line posterior. 1 point. ठीक है sir? Now here many things are coming out nowadays. Once is said, one can hold a bone holding your clamp to between these two to maintain the reduction.
Yes.
Now newer concepts are coming out. Now you see in the X-ray whether the reduction is there or not. People are nowadays going for arthroscopic evaluations of your syndesmotic joint. If you are saying that it is not entirely depend on the screw, rather before that I will try to apply a clamp to hold this together and evaluate in the X-ray that I am having a good reduction. I may not have it. If it is not, even you can go to the inside the joint and do the reduction. This is arthroscopic assisted reduction. Nowadays concepts are coming out. Now screw principle is that earlier day it was lying down, and nowadays they are saying if it go high, even 2 screws. 2 screws, how many got? 1, 2, 3, not 4. So your principles are there. At number one, that I am passing the screw from the lateral side to medial side in the angle of your 1 point. Before that, I will try to do a reduction to the reduction plan. Selection of the screw is basically fully threaded. This is not a compressive screw. This is a positional screw. So you maintain this and is maintained position. I do not want to give additional compression to this area. For this, people are doing like this. So in this position, the greater part of the talus is accommodated. That is why there is no further compression will be possible since it is preventing it. Yes, sir. So the screw selection mostly you can go for even 3.5 or 4.5 depending on this size. This is not a compression screw. So these are the principle. Okay, sir. One can go even 2 screws. They said even if you want 2 screws. That can be done through the plate. So that is the concept. Now nowadays they are saying compression, evaluation, if necessary, go arthroscopically see, no reduction, reduce it, clamp it, then screw it. Screw may pass through the plate itself. So that is your semester. Regarding medial malleolus, what to do? Where to put the incision? What is the important structure coming up here?
Stephanus.
7S now also. So we have to take care of this part 1 point. Number 2, one can go a bit anteriorly. Incision can be done over the bone or over anteriorly. Why it is over anterior, towards the anterior side?
We can inspect the joint cell.
Correct. To inspect the joint. Sometimes while the talus is in rotation, it may cause crushing of this part. Are you getting my point? Not purely on the fracture there. It may cause the injury to the plafon also. Why? Because of this, because of the talus which is in rotation. So that is one can inspect this one at 1 point. Number 2, always while doing the reduction of the medial malleolus, always try to look at the anterior border. Why it is important? It is said the serrations may be adapted here. You will find a good reduction, but it is not actually good reduction. It is sometimes going anteriorly or posteriorly. So whether your reduction is perfectly okay or no, one should go for the anterior border. So that is why even if you are putting incision like this, one should look at the anterior border that I have a very good reduction there. Rest of the part of the fixation depends upon the size of the bone. Size and quality of the bone. If the size is very small, it will be not possible for us to address it with a malleolar screw or a cancellous screw. What are the screws you usually use? Earlier the malleolar screw, nowadays people are going for 4 mm, your cancellous screw. Can also important. So and they are saying that even if you are giving 4 mm, better to give 2. One is a bit anterior, a bit posterior. Okay, sir? So their concepts are coming out like this. So my reduction should be there. What is the most important thing while doing reduction? Many times you will find the periosteum is going in. Because there is a avulsion of the fracture here, and while it is coming back again, it will invite the soft tissue in between. This is one of the reasons behind of non-inner medial malleolus where X-ray is acute. X-ray is okay, but X-ray is silent, but even X-ray is good, reduction is good, but even is going for non-linear. Why? Because the interposition of the soft tissue. So interposition of soft tissue is to be addressed, do a good reduction, and you have to look for the anterior border particularly that I do have a very good reduction, and fixation depends upon the size. If it is small, tension band wearing. If it is big, 2 things, one can go malleolar screw, another can go for cancellous screw, even then there is a combination of also. Sometimes cancellous screw and again tension band wearing. So it depends upon the stability that I am having it or not having. So you have to decide which is best at this moment of time. So you have the option like this. Okay, sir? And what about your deltoid ligament injury? What about the ligamental injury? There is new things are coming up. Nowadays, do not leave it like this. They said you can go for encourage. you have to repair it. Yes, new things are coming up, so to address the deltoid ligament also. So you cannot just leave it like this. So many times you will find this injury. What do you say, ankle sprain? Once it is ankle sprain is there, this patient is prone for repeated injury. Why so?
Instability.
Instability.
Instability. Because of the time and the uneven surface is working, she is unable to hold it, that is why she is falling again. And initial treatment is very important. This patient may need surgical repair of the reconstruction treatment. Otherwise, you will have repeated trauma. It is all because of the fact that the initial trauma which is happening did not have a very good repair and is unable to address the stability. That is why she is prone case of your instability and recurrently she is having this. Cannot leave it like this. So there is a reconstruction techniques are coming up so as to address this. Yes, sir. So one can give as such physiotherapy is very important to strengthen the muscle around so it will give a support. Ligament is gone, but the other structures are strong enough to hold it. That can be done. But nowadays things are going in this direction that who is a prone candidate for your recurrent fall is a candidate for surgical reconstruction also. Yes, sir. So you cannot leave it like this. Not clear.